Gail Boudreau, President and Chief Executive Officer of Anthem, a Fortune 50 company and leading health benefits provider serving more than 40 million consumers through its affiliated health plan. In total, Anthem serves over 73 million individuals across 27 states through its broad portfolio of health insurance and service subsidiaries. Gail previously was the former CEO of United Healthcare and prior to that, President of Blue Cross Blue Shield of Illinois. Ken Frazier, Chairman and of the Board and Chief Executive Officer of Merck. Ken has substantially increased Merck's investment in research, including early research, while refocusing the organization on the launch and growth of key products that provide benefit society. He's led the formation of philanthropic and other initiatives that build on Merck's 125 years plus legacy. And of course, last but not the least, my good friend Norman Augustine, retired Chairman and Chief Executive Officer of Lockheed Martin Corporation. He served as Assistant Secretary, Undersecretary, subsequently Acting Secretary of U.S. Army. He's been on the faculty of Princeton, served as Chairman and Principal Officer of American Red Cross, and the Chairman of Defense Science Board. Now, Norm is a member of the National Academy of Sciences, National Academy of Engineering. You have to be a member of our National Academy, Norm. And most recently, as you heard, he chaired the Academy's major consent study, Making Medicines Affordable. So let me just get right into the issue. We heard many, I think, aspects of this whole issue of affordable drugs. I'd like to cover today quite a bit of waterfront, ranging from the complexity of our system, particularly when you think about pricing, to innovation, which is so important to all of us, to, as you heard from Secretary, the issue of price negotiation that, Norm, your report talked about, to value-based pricing, particularly as we look at what kind of tools do we have to assess technology and the scientific advances, to the issue of generics, importing drugs, and if time allows, I have a lot more other questions. So let me begin by saying, Norman, that report of ours, remember when I came to the study committee, I said, can you explain to me the complexity of the system, right? I mean, to my knowledge, there's the drug manufacturers, there are the wholesalers, there's pharmacies, there's pharmacy benefit managers, health plans, and employers. So that interplay of all these players determine to a large extent what the patients pay and what the price ultimately is. And so with that many complex system, is there a way to streamline this? I'd like to ask you that question first, and then maybe turn to Gail for her to particularly think along insurance plan, PBM, and things like that. Norman?
Right. Thank you, Victor. I probably should say there are many of you that are wondering, what is an aerospace engineer doing as chairing the panel on the pricing of pharmaceuticals? And that's what I asked Victor when he first got me into this. And I can think of only two reasons. One reason is that I come from an industry that's highly regulated, has a major customer that's the federal government. The second reason I can think of is this is really a hard problem, and I am a rocket scientist. So that is background to Victor's question. You might think as an outsider coming, you have manufacturers who produce a drug, physicians who prescribe the drug to their patients, and the patients purchase the drug and use it. That would be the simple model. As you cited, there are some other elements. There's a third party that pays many of the bills, namely the insurer, often the federal government. There are wholesalers, there are retailers, the physicians, there are regulators, and then there's this other entity that's fairly unique to this industry. I guess it's totally unique, pharmacy benefit managers called PBMs for short. And to totally streamline the industry would be a huge change, but it did seem to our group that there are ways working with the system that you can preserve the market forces that exist, they use much more powerfully in the cost, reducing the cost of pharmaceuticals. Another element of this, of course, I'm sure you're going to come to it, while you're reducing the cost of pharmaceuticals, you don't want to undermine the ability to develop new products for future use. And that's, I suspect, something else you'd want to raise.
Thank you. You know, I failed to give you all 5 minutes first because I'm so eager to jump into the subject. So why don't I take a step back and make sure that you have a chance to kind of really give us your perspective before I kind of hit you with really hard questions. So how about if I start, therefore, with you again, Norm?
Okay.
Tell the joke again. They really like that.
Thank you. Well, I would just start out by saying that this is a truly important issue. The price of pharmaceuticals and the balance with ensuring that research can be afforded. This obviously has an important impact on the quality of life of our citizens. And it's not unlikely that there are people in this room who would not be alive today were it not for the research performed in our pharmaceutical companies, in our universities, and by our government. Last year, at the end of the year, a survey was conducted of the public in which it was asked, what is the most important problem that the Congress should be working on as we approach the end of last year? And the number one item that came up by a considerable margin was the control of the cost of pharmaceuticals. That ranked above reducing the deficit, above raising the minimum wage, above reducing taxes, rebuilding the infrastructure, and so on. That's how important the public views this issue. The average American spends about twice as much on pharmaceuticals as do citizens on average of other developed countries. And as the Secretary referred to, Americans are paying some of the bills for people in other countries. Some would argue that that's fair. We're a wealthy country. That's an issue in itself. The really tough issue here, the underlying issue that our committee ran into, was is the provision of pharmaceuticals or healthcare writ large truly an entitlement that everyone should have independent of their personal means, their financial means? And if it is, can the nation afford it? That's sort of the fundamental moral question, and the practical question, which the nation has really not answered yet. It's in this sort of an environment that the NAM, with Victor's leadership, set up our group, which consisted of 17 members, quite diverse in professional backgrounds. Went all the way from economists to physicians to business executives from the pharmaceutical industry to academics, patient advocates, and one aerospace engineer. Kind of like a partridge in a pear tree, you could say. I can also point out that some of my colleagues are in the room, incidentally, and I owe them a great deal of thanks. I should point out that each of our recommendations enjoyed the support of at least 88% of our members. Many of the recommendations enjoyed unanimous support. We found that there are really only three basic alternatives. The drug companies, I think, need to think about this carefully. One alternative is to continue basically on the path we've been on. A second alternative is to modify the existing path to try to maintain, as I said before, as much of the free market forces as one can maintain. The third is to go to an entirely new system, presumably a single-payer system, widely adopted elsewhere in the world, where that single payer, the government, either de facto or through direct authority, sets prices and also controls formularies. Let me close, let me just very quickly go through some of our findings We came up with 32 findings, 8 recommendations, and 27 implementing actions. I will only do 3 or 4 here in terms of recommendations. The first of which was to rebalance the negotiating power between the drug providers and the patients. And as you heard, at present in Medicare Part B, it's against the law for the government to negotiate prices. Another proposal is to enhance market competition by eliminating marginal, sometimes abusive, extensions of patent protection, known as evergreening. And to eliminate practices whereby potential generic producers are kept out of the market by being paid to stay out by the patent holders. That's referred to as pay to delay. We also propose increasing the transparency of the flow of funds all the way from the laboratory to the patient. We propose eliminating the misapplication of funds in federal discount programs that are intended to aid vulnerable populations, are often used for other purposes. We propose terminating the tax deductibility of direct-to-consumer advertising of prescription drugs. The United States and New Zealand are the only countries that permit that. And lastly, for my comments today, we propose that the FDA should seek reciprocal arrangements with regulatory agencies in other countries for generics and biosimilars, whereby we could agree upon the safety and viability and of the drugs, including such countries as Canada, Great Britain, Australia, New Zealand, and so on. And that's probably a good place to stop, Victor. I think we've probably offered enough to offend most everyone there.
Thank you, Norman. John?
Well, thank you, Dr. Zhao. It's terrific to be here, and it looks like you found my bio on the website. The one I prefer is that I'm a pharmacist who became a pharmacist when my mom got sick. I wanted to be a sports broadcaster, but I was fascinated not just by the role that medicine played in her life and the science and technology that led to not just the discovery of therapeutic action, but the ability to get something out of a petri dish into a bottle, into a patient, and to the site of action where it's needed, and all the innovation and other challenges that are behind that. But how there can be such a difference between 2 5-milligram tablets of something that look very similar but behave very differently. So to be here today representing Secretary Azar and the work that he's doing to implement the President's blueprint to bring drug pricing down is an incredible honor. I think in the last 5 months, hopefully many have heard what the Secretary described in terms of the 4 problems that we're trying to solve and the 4 ways that we're going about it. And of course, the Secretary did such a great job that there's no point in recapping that. But I have noticed that in the 5 months, we've gone from, oh, this is just going to be an RFI, to, wow, there's been a number of actions released. To some of these are singles and doubles, but over time, runs are starting to come across the board. As the Secretary noted, we've had 15 drug companies, including Merck, thank you very much, who have decided to either lower a price or roll back a price increase or freeze their prices for the remainder of the year. And we saw a company take a couple drugs in a very important class, and even though they had patent protection for many years in the future, decide to introduce an authorized generic that will ultimately allow them to lower the list price of that drug so that patients can access those drugs at a much lower cost if plans indeed choose to cover them. Which gets to the complexity of the system that you described, and you hired a rocket scientist to help solve. Because it should be easier for companies to be able to lower their list prices to something similar to their net price and begin negotiating from there. But as the Secretary has described, the system hasn't necessarily worked to make that easy as it could be. I'll just echo what the Secretary announced today, what a big deal it is for him to take the step forward. It did post on the Federal Register at 4:15 for those of you who don't have service and are still trying to refresh the website, that we are indeed proposing that drug companies will be required to post the list prices in their televised advertisements, so that in much the same way they have to disclose the major side effects of a drug, but not the effect that buying that drug could have on your wallet. The Secretary believes that we deserve more transparency. And just over the course of the last week, if you see the President signing the action on gag clauses to prevent pharmacists from telling patients how they could save money by not using their insurance, that move towards transparency continues by proposing that these prices be included in their ads. Not everybody understands how important list price is. I think today many patients either pay list price or prices that are calculated on the list price. Secretary described how list price factors in to the coinsurance that's present in every plan, every Part D plan that seniors are enrolled in today. More and more people have high deductible health plans. More and more people have separate drug deductibles within those health plans. So the impact of list price is real, and hopefully this information will create that conversation between patients and providers and others to help determine the value. Because if we're truly going to move to a value-based healthcare system, and value equals benefit over cost, we can't get there if we don't know either the benefit nor the cost. I think it's important to note that we're also exploring additional ways to improve drug price transparency and consumer decision-making, all of which were described in the blueprint, and hopefully many of which will be coming soon to a payment rule near you. But again, I just want to thank the Academy for the work that it's doing on this topic. And I was going to hold up your book and wave
Please
it
do.
if you could do that for us.
Autographed copies.
Oh, that'll be awesome. But more importantly, for the opportunity to be here today. So thank you very much.
Thank you. Thank you very much indeed. My friend Gail.
Great. Well, thank you, Dr. Zhao. It is really a pleasure to be invited to participate on this panel. I think the themes that Secretary Azar outlined are really important as we think about transparency, a complicated healthcare system that really does need to be simplified, and affordability at the core, and the role that consumers play. I think those themes are critically important. I mean, we are at a time of incredible clinical innovation and discovery, but affordability overhangs that entire discussion. And affordability, I want to put a little bit of perspective on that, because I think talking about just drug affordability, this is I think we need to be thinking more broadly about total healthcare affordability, and drugs certainly are a very important part of that. Just thinking about, at least from our perspective, the industry that I'm in, a family of four today in a average employer health sponsored program spends about $28,000 a year, including their copays. That is a huge amount of money in terms of most people's incomes. Looking at the individual market, where if you're not on a subsidized program or get one of the subsidies, you can pay almost $1,000 a month in just premium, and then also have to add copays and other things for your pharmacy benefits. So those kind of issues, I think, are significant. Drug costs historically have not been in the majority of the conversation around total costs, but now it's over 20% of health insurance premiums, and it's one of the single largest areas that is increasing year over year. So clearly this issue is important, not just for this industry, but for all Americans. And I agree with Secretary Azar, it's something that we have to come together and figure out, working together, how to solve this issue. And I do believe that there are important partnerships that can happen across the industry. We at Anthem have been working on many of those partnerships. We actually began on the policy front, working with Eli Lilly several years ago to try to introduce two new policy formats, basically to mitigate some of the issues around legal risk and discussing value-based payments. So how do we move the dial forward on value-based payments? In 2016, the FDA did approve one of those, which allows insurers and manufacturers to talk about drugs prior to them being approved, which was a step in the right direction. We're also, as a result of the blueprint that has been shared, have been talking to over 10 different drug manufacturers about how do we move the ball forward on a couple of areas. One being fixed pricing, which I think at the core of this entire discussion is around lowest net cost of healthcare. And I think we can never forget that in the midst of many of the discussions that we're having. Value-based payments are one opportunity to get there, but ultimately lowering costs for all consumers in terms of these copays and what they pay. At Anthem, we are in the process of launching a new PBM. And I guess as you think about PBMs, and to Victor's earlier question, sort of what is the role of the PBM? Well, PBMs have had an important role in drug distribution and in working on how plan designs are integrated in moving more consumers toward generics and, quite frankly, bringing the cost down of overall therapeutic categories. But that's not enough in my view. We really need to look at integration. Right now we have a fairly fractured, disintegrated system. And it's not just about outpatient drugs, it's about total cost of care, net cost of total care. And as we think about that, the new generation of PBM, in my mind, what we're trying to launch is a PBM that fundamentally looks at whole person care. And what I mean by that is takes the information from not just medical, not just pharmacy, but behavioral, dental, vision, all of the aspects of a person's interaction in the system, brings that information into the hands of care providers and allows both consumers, patients, and care providers, and those payers, the opportunity to help consumers make the right choices through transparencies. And I think that type of unique clinical model is the next generation and the next opportunity for us. And just one data point, we launched some of this work several years ago, and in 2017, by our ability to integrate both medical and pharmacy, and that isn't necessarily how standalone PBMs think. They often think about, where ultimately, the specific thing around outpatient drug costs can be driven. But if you think about the right intersections, the right points between medical and pharmacy and behavioral health, we were able to demonstrate that we could decrease premium increases or trend to less than 2%, which is traumatic. But that means looking at inpatient costs, outpatient costs, behavioral health, as well as pharmacy in a completely integrated way. So I'll close my comments really with the last area, which is, as we think about, I think, the blueprint and the challenge that has been brought out for all of us who are part of this industry and the overall key point about affordability, I do think we have to modernize the way we contract for pharmacy and drugs today. If you think about it, across the rest of healthcare, we have been moving very much towards a value-based pay-for-performance system versus a pay-for-volume system. And we at Anthem today, about over 70% of our hospital contracts have some pay-for-value elements in them, and we're moving to much more heavily pay-for-value. We work with about 159 ACOs and 79,000 providers who take risk or share value. Yet our pharmacy, our drug contracts are basically the same as they've been for over a decade, if not longer. And that has not moved to value-based. It has not changed. And one of the elements of that hasn't changed is that manufacturers, similar to what Secretary Azar shared, can change that pricing at any point in that contract, and often do. And that creates a burden both on how we think about it, because we price 18 months, as does the government, in terms of our contracts with Medicare Advantage and Part D, ahead of those. And so when you change those type of mechanisms inside of a contract without set pricing, that creates increased costs for consumers. So I believe that there are opportunities for us to work together. And I would say that as we think about embedding fixed price contracts, longer term contracts, we can take the current structure around rebates and set fixed prices so that we have a transition into more determinable costs. Two, that when drugs are added to therapeutic categories, that we bring down the overall cost. That is not the case today. And third, I would say, as we look at unit costs and total costs of pharmaceutical and drugs, that we are fundamentally looking at value, and not value in the broad sense, but really impact and output to specific patient classes. So it is not the broad version of value, but what it really drives for specific patients, that there's an opportunity through advertising and other things to target patients where the drug really has efficacy and impact. Secondarily, that impact is judged based on patients, care providers' input, as well as payers, because again, this all comes back to affordability and the opportunity for us to actually create more things inside of our system that drive unique value, give consumers choice, because they are paying a big portion of these costs, as well as be able to have specific clinical interventions. And the last piece I would say, and Dr. Zhao asked, and the question is this issue of complexity, and I think we touched a little bit on, the role of, should we have single formularies? I do think we are a system driven on consumer choice. And consumers should have transparency and the opportunity to make decisions. Today, in the policies we sell, they do have an opportunity to make those choices either with their employer or in an individual market or through Medicare Advantage, where every single year they enroll. And as you know, today was the beginning of that enrollment process where they can compare very specifically different policies. And all of our policies are on our website, and we have not had any gag clauses. What we do ensure that is that when an individual goes to a pharmacy, that we provide them with the lowest cost. So whether that is part of what's in our copay, but the lowest absolute cost relative to our negotiated rates. And the last point I would just bring up in terms of that, what's really important is the reason we want them in the system is that if we don't have a chance to capture that data, we don't have the opportunity to integrate it with the rest of their health care. We don't have the opportunity to help them close gaps in care, look at different ways that drugs are being prescribed, quite frankly, across potentially their behavioral health and their medical policies, or potentially their disability. So that integration of information and data is really important, and that drives the transparency. So thank you very much.
Thank you.
I'm really looking forward to a spirited debate.
Okay. Ken.
Thank you, Dr. Zhao. I want to thank everyone here for having me here this afternoon, and I want to congratulate the 85 new members of the Academy. I want to bring this back to the patient. I think that's really what we should be focused on here. And today, as you know, all over this country, patients receive for the first time a diagnosis of cancer. And that word strikes a primal fear in patients unlike anything else. And for these patients, when they heard that word, their fundamental concern is the malignancy itself, the tumor growing inside their bodies. And for them, the fundamental hope is for their survival. And those hopes, I think, have never been as well-founded as they are today. We're in an era where decades of translational research are yielding breakthrough treatments that transform and even cure diseases, and cancer is one of them. I agree that with these new treatments have come significant issues of affordability. I also want to say, though, that we are now living in an exciting time. We talked earlier in a panel about the unprecedented scientific advances like immuno-oncology and CAR T therapies that provide that new hope. Well, Senator Cassidy.
Hi. Nice to see you.
Thank you for being here. Here first. So let me welcome Senator Cassidy. And I know he went through trains, planes, and automobiles to get here. The weather elements have been actually quite challenging. And the fact that you came to our meeting, and I know you're not in session, we greatly appreciate your presence. I'll give you your introduction shortly, since Mr. Frazier is in the middle of talking about his point of view about patients. And we've gone through, in fact, along the panel, this sort of 5-7 minutes of summarizing your thoughts. So I hope that you'll be next.
Okay.
And so, Ken.
So I was just saying that we're, again, at the forefront of tremendous advances in immuno-oncology at Merck. We are studying our drug, which is one of many immunotherapy drugs like Keytruda. Right now, we're studying it in 30 tumor types. We have evidence of activity in 25. It's already been approved in 8 tumor types for 12 indications. And when we talk about the benefit of this drug, we're not just talking about patients living longer by a couple of months. In a recent study, we were able to show that if you add this drug to the standard of care, that you reduce the risk of death from non-squamous, non-small cell lung cancer by 50%. And we're not talking about people living 2 to 3 more months. We know from the data that we have so far that patients are living much longer. 70% of those patients are living at 1 year, and we haven't even reached the median for overall survival. So that is a significant breakthrough. And the question becomes, how do we now think about the value that that drug, which has significant incremental costs when you add it into the system, has for society? And I would argue, to the point that Gail just made, the first question is, what is that incremental cost versus the incremental benefit to that patient? We're talking about unprecedented survival advantages. There was a discussion earlier on about if you list all the cancer drugs over the past 25 or 30 years, many of them didn't cause people to live very long. I think we need to look at individual therapies and make a judgment about what that really means. I know that I have to close right now, and I'll just make one more point. And that is, when you think about it holistically, there was a study recently from the University of Chicago that said reducing cancer death rates by just 10% in the US would be worth roughly $4.4 trillion in economic value to current and future generations. So I'll come back to the point that if we're going to have a serious discussion, we have to look at cost holistically. We can't just look at drug prices in isolation. I heard the comment earlier that drug prices are 50% of cancer costs in this country. Well, that depends on what you mean by drug prices. There are data that say it's 20%, but with hospital markups that can be 500% on the manufacturer's price, it gets to 50%. So it's really important for us not to have these kind of high-level discussions without focusing on specifics. Thank you.
Thank you. I think this is, we're setting the stage for a really great conversation. But let me welcome Dr. Senator Bill Cassidy, who is a senior United States Senator from Louisiana, serving since 2015. He's a trained gastroenterologist. And he previously served in the House of Representatives from 2009 to 15 and the Louisiana State Senate. Prior to that, he provided care for the uninsured and underinsured patients in Louisiana's charity hospital system for nearly 3 decades. During this time, he co-founded the Greater Baton Rouge Community Clinic, providing free dental and health care to the working uninsured. Also created a public-private partnership to vaccinate 36,000 Greater Baton Rouge area children against hepatitis B, no cost to schools and parents. And like everyone in this panel, I've had the pleasure of interacting with all of you. And maybe John, my first time meeting you, but certainly with your colleagues. And I would say about Senator has welcomed us, have engaged us in many discussions, and certainly this is an area he cares about. So, Senator?
Thank you, Victor. Thank you for having me. I really appreciate it. Really am honored to be with this panel. So Victor mentioned I was a gastroenterologist. I worked in the public hospital system of Louisiana, which took care of the uninsured. And I actually started my training at Los Angeles County Hospital, USC, in Los Angeles at the advent of the HIV crisis. And I'm struck how when I was a resident and we first began seeing HIV in '83, patients, it was a death sentence. Everyone died. Everyone died. And then we began to get therapies, but I would see my patients at Earl K. Long Hospital in Baton Rouge, and I just remember a young lady, such a poignant story. Her mother had pimped her out. She was an adolescent young woman, and you know, the older men liked these teenage girls thinking that they would be clean. And she had such terrible HIV, and she had no sensory input. She had had an meningococcal infection of her spinal cord, and she just laid there blind and deaf, moaning in her bed, rocking back and forth. That's all historical. That doesn't happen now because of this incredible innovation that has occurred in the pharmaceutical industry. And I could go on about hepatitis C. I'm a hepatologist, actually. This group may know what it is. Everybody else thinks it's snakes and venereal disease. And so I'm actually a hepatologist treating, and that which formerly was, oh my gosh, it could lead to liver cancer and transplants and cirrhosis with all those complications, is now curable. Just incredible. That's wearing my doctor hat. Now let me wear my Senate hat. My Senate hat, I'll say that the financial burden of drug cost is something that can cripple our nation and also obviously can cripple families, and does. Now let me quickly point out that there are really rarely villains in any of the supply chain, but there's villainous incentives. There are terrible incentives which work against that which should be primary, which is the patient, and then just after that, the taxpayer. I can give you examples. I can give you examples that we perhaps all know of two over-the-counter drugs which together would cost you $20 out of pocket. They're packaged together and sold on Medicare for $2,000 a month. $20 of generic for $2,000 a month. The Medicare rebate system, which actually was supposed to be rendered to the benefit of the patient and of the taxpayer, and now probably cost them more while saving pharma and saving the manufacturers money. That's slick. I'm just telling you, that's slick. Pay for delay, a drug which has been off of patent for years, which is $48,000 in the US and $8,000 in Canada. Or the 340B program, where there is evidence that hospitals and facilities on the 340B program actually are less likely to treat the Medicaid and the uninsured. Now that's upside down. Now there's a tension. Profit-driven innovation, which means that no longer am I scoping somebody at 3 in the morning at a public hospital for the uninsured, banding varices secondary to hepatitis C-induced cirrhosis. Isn't that fantastic? Versus the exploitation of regulations for profit. That is existential for our country and for many families. This is what we must resolve. I personally favor market solutions. Right now, we do not have it. We have entities that are on both sides of the transaction. They know both sides, but the payer does not. Guess who does a heck of a lot better in that transaction? And so I think we need to return to where we do have market-based solutions. My fear is that the hard left will take over, and they'll have less visceral respect for the profit-based innovation that I have so seen, and more disregard for the exploitation of regulations for profits. And that which is, as Ken mentioned, bringing us to the advent of cures of cancer that we just never thought could be cured before. Somehow that will die a borning. Not right away, but it will gradually, before we get that cure for Alzheimer's or the cure for other cancers. So wearing my doctor hat and my Senate hat, I try and put them together and say, the solution would be if we go back to making that patient and that taxpayer primary, and if we do that, not just as a matter of rhetoric or as a throwaway line in a conference like this, but looking at each regulation and say, does the end result mean that it's going to be, all things considered, better for that patient? Right now, it's not. Not for the diabetic who can't afford her insulin. If we can make it that, then we will have accomplished our goals. Thank you.
Thank you very much. Okay, so perfect. Let's first deal with the blueprint, right? I think you mentioned how many items are there in the blueprint, John?
There were 165 questions outlining about 50 plus separate actions. And it was organized in such a way that there were things that the Secretary and the President knew we wanted to do with the stroke of a pen. There were things that we knew we would need to partner with Congress to act on. And there were things that we knew we could do via regulation, but they had the potential to be so disruptive that we wanted to get feedback from the public and get it right. And we received over 3,000 comments, and we appreciate all those who took the time. I think July 11th was the end of the comment period, but not the end of public input. We continue to appreciate those who have come in to share more information with us about what we should be doing differently, and look forward to more to come.
So in many ways, Senator Cassidy, more or less says, yes, we got to fix it. We got to look at every single area where do we have misaligned incentive, right? Blueprint's trying to do that in some way. You call these singles and doubles, but not home runs. Right? So how many singles and doubles do we need to really fix the system? And how will you be able to tell me at the end of that great initiative that you have, what is in fact the collective evidence for savings and what percent?
No, I think rather than throw out a very specific target of like, this is the goal that we hope to have by the end of the year, we are measuring the progress that we've made by the actions that we've taken and the response to them. So again, many people said that the blueprint fell short of what the president promised, which was negotiating for drug prices. And the secretary rolled it out in the Rose Garden and said, no, we're actually going to improve the negotiation that we have in Part D, and we're going to begin negotiating where we haven't seen it in Part B. And we began to ask for feedback, and we ultimately gave Medicare Advantage plans the ability to use step therapy and cross-manage Part B and Part D drugs for the $12 billion of drug spend in Medicare Advantage plans. Again, I think as people look at, oh, what are you going to do? Well, here's what we announced that we were going to do. And then today, on the first day of enrollment, we saw Medicare Advantage plans who had to work really quickly, right? Many of these negotiations were already closed, and they were given new authority, and they went out there and they began renegotiating, and they've announced how they're going to do it. But there are two key pieces of that. One was patient protections, making sure that patients who are stable on their existing drug were going to remain on that medicine if their doctor felt it was best for them, and doing so in a way that reduces physician abrasion. We don't want doctors to be barraged by faxes and patients waiting at the pharmacy counter. We believe that there are electronic tools with which Medicare Advantage plans can do that better. But ultimately, we wanted the savings this year to be shared with the beneficiary. Now, next year, in the next benefit season, going into these negotiations, knowing that they have this authority, there's the ability to save money on those costs and ultimately see lower premium. So perhaps next year we'll be talking about the premium savings that are attributable to improving the ability of Medicare Advantage plans to negotiate. But I think that's just one example of sort of the, we asked some questions, we said we're going to do something, we did it, the private sector responded, and this is the result.
Norman, I think in your report, you propose collectively the government sectors together negotiate pricing. Right? Can you expand on that a little bit?
Well, yes, the proposal we had was that that states would have the option, if they wish to join with the federal government in negotiating prices. And the benefit of this, of course, would be it would give those representing the patient a bit more leverage in the market. This is not an easy thing to do, as we've just heard, but it was our view that until we do get a collective way to negotiate prices, we're likely to continue to face the kind of problems we've been facing.
Senator Cassidy, what do you think about that approach?
I have a couple concerns about it. First, and that may seem a little paradoxical, I'm always afraid of monopsony pricing, whereby the purchaser is such a major purchaser that the purchaser can dictate the price. Now, again, we have this tension between profit-fueled innovation or profit-taking. Now, it's going to be, we're going to get there. We'll get there. The best way to balance that right now, I don't think we have. But if it's a monopsony-based type pricing mechanism, then I truly think that it's going to be so tempting for someone to say, we can lower costs. We're just going to pay you this. And venture capital flees. And again, it flees before we have a cure for Alzheimer's, as one example. Now, it may seem a little counter-paradoxical. I'm also fearful on the other side of industry capturing the regulators and coming up with this Byzantine type of negotiations, which we have now, in which on the backside, folks end up making far more money than is apparent. And so I'll lay it out like that. I'm not adverse to it, but I do think there has to be safeguards as to how we do it.
Gail?
Well, I think first, there's a couple issues on both. One, I think the flexibility on Medicare Advantage makes a lot of sense. It's an incredibly competitive market. It is a choice market where seniors make a decision with the help of guidance each and every year. So I think the flexibility that the administration has allowed the plans allows us, as I think Secretary Azar talked about, when you have a category of drugs that really do work, we're happy to cover those, but we shouldn't be extending them to categories where there are other alternatives that make more sense for patients. So I think, first and foremost, the private system works very well that way when it's given the flexibility within those right boundaries. The second issue, responding directly to should the government just be the negotiator, fundamentally we believe that the private market can work. Will work, but I think we have to ensure, remember, one of the major opportunities around this is formulary placement. And so pharmaceutical companies negotiate with payers around, which drugs are on and off their formulary. And also, if you really think about consumer choice, if the government is going to negotiate wholly, as many countries do, it's a single formulary without any patient choice. They make the decisions. And that, I think, goes against sort of the tenet around individuals should have that opportunity to choose with great transparency. They should have, obviously, better tools to make those decisions, and it should be clearer. The last point I'd make is, if we really do believe that total costs, and I do fundamentally, that we are talking about lowering overall healthcare costs, that there are transfers between effective drugs versus other things that we're doing inside of the hospital, that those trade-offs should be looked at as what's the best possible outcome for the patient, then I think we have to be looking at total costs. And if you have the government negotiating solely for pricing, I think that really stifles payment innovation, because what manufacturer is going to be willing to enter into a value-based payment arrangement or other things when the prices are already set. So I think that there's a number of complexity, as we've talked about in the system, but taking the right steps that we've talked about, which is trying to get to, absolutely, fixed longer-term costs, moving towards value-based payment, transparency for consumers so they see that, starts moving us in the right direction.
Ken?
Well, Gail hit a lot of the points that I was going to make, so let me just summarize a couple of comments. So first of all, we live outside the U.S. in markets where we, quote, negotiate with governments. I can tell you that's an overrated experience, that negotiation, because what they do is they dictate the price. And I just came back from Japan, where they have a short-term budgetary issue, and guess what? They renegotiate the price. They just come in and say, the price we agreed to? We can't afford it anymore. The challenge that you have in those systems is that essentially the government is deciding at the end what the value of the innovation is. And that has some advantages. The prices are inevitably going to be lower in that situation, but as Gail suggested, there is going to be, in the final analysis, less choice for healthcare providers and their patients in those systems. The problem with our system is it relies on insurance largely, and it provides inequality. There's some people who have good insurance, there's some people who don't have good insurance. There's some people whose drug coverage allows them to pay relatively less out of their pockets, and there are other people who don't have that kind of coverage. Someone said the administrative costs in this system are higher. But I think one of the things we have to be very careful about when we say our system is broken, we have to be careful not to look for simplistic answers. It reminds me of the conversations about our broken educational system in this country, K through 12. We have to engage and think about these thoughtfully. We have to bring lots of people to the table. Senator Cassidy is absolutely right. We want to make sure that patients can have access to these medicines, but make no mistake about it. It is not easy in today's world, when we are going after diseases that have evaded cure, to convince people to provide the patient capital to go after Alzheimer's disease. And if the marketplace is such that people believe that the rewards associated with this risk that we're taking over a long period of time are not going to be sufficient, then I'm just worried that we will not get the capital markets to give us the length of time that we need to find these new drugs.
So Ken, since you raised this, let's talk about innovation then, right?
I'm sorry?
Since you raised this issue, let's talk about innovation.
Yes.
I mean, it's always been said that to support innovation, that companies have to make a good profit. I mean, good is to be defined, but still, you know, you're saying that, look, if we're not able to have a reasonable profit, it's difficult to support innovation. And yet, it's not clear to me how one determines how much you invest into your R&D, right? And data shows that actually two recent reports says that 70% of the new drugs actually come from the smaller startup biotech, which, you know, pharma has been successful, able to license in or acquire, et cetera. And so what is disconnected in this picture here?
So there's
a large amount of R&D necessary, and yet the innovation so much occurs, as we all know, in the smaller innovative laboratories in universities, et cetera.
Well, I think that's a generalization, but let me just say that we spent $8 billion a year at Merck on R&D. And a lot of that money is being spent, as you suggest, by bringing things in from the outside. There's an ecosystem right now. Research is much more distributed than it was 25 years ago, as you know, as an academic. There's venture capital. Those folks can develop opportunities, and often pharmaceutical companies purchase them. We're actually still a research and development company at Merck. We're not a search and development company, for the most part. We believe in basic research. We've opened up new labs in Cambridge, in South San Francisco, and London in the last few years to do basic research. So we still believe in that. At the end of the day, though, I want to go back to this drug that we're talking about. We are now running 850 clinical studies for Keytruda. That's how we can see today activity in 25 tumor types beyond the 8 approved tumor types. So what we bring to the table beyond just the early stage research is the capital investment that's necessary to get these drugs to people quickly and get them to them globally. And that's why it makes sense to have an ecosystem of small companies with a few researchers over here and large companies that have the kind of capital intensity that you need to get these drugs everywhere.
Yeah, do you think that, in fact, our current system of approval, clinical trials, which is very costly, is one of the reasons why you need such capital intense, and whether we really need a fundamental change in the way we actually approach was development, clinical trials, and approval?
Well, I think the FDA is doing a terrific job with some of these really important drugs, but I do agree that there are ways of streamlining regulatory science to make it keep up with today's science. And the FDA, for example, this year, for the first time, approved an indication across tumor types based on a genetic signature. And I think we're going in that direction in the future. I think with artificial intelligence and a greater understanding of human biology, we can reduce the cost of the regulatory period.
It is fair to say, if you look at the cost of drugs, as Norm said, is extraordinarily high here compared to others. So in many ways, when multinational companies say, look, you know, we need innovation, we need the kind of income that comes with it, I think U.S. is paying for the other countries to a large extent.
We pay almost
right?
50% of the cost of research in our country, and the rest of the world splits the other 50%.
I mean, can something be done about this?
Can I interject?
Yeah.
But it's also important to note that the initial price of a drug does not necessarily have a relationship to that cost of R&D. And there was an article in the Wall Street Journal from a couple years ago where Pfizer had basically figured out, you know, this is how much oncologists will pay for a medicine and not be sticker shocked. But it was quoted in the paper, in the article, it had no relationship to the R&D. I'll also point out that this drug Gleevec, which has been off patent for years, 48,000 in the US, 8,000 in Canada, that's not R&D. That drug has just gone up dramatically since I was prescribing it way back when. And so yes, we need to get profit-driven investment, but some of this is just profit-taking.
Norman?
Picking up on Senator Cassidy's point, our committee devoted a great deal of time to this question, and although the data are somewhat opaque, it does appear that the pharmaceutical companies devote a greater percent of revenues to research than does most any other industry. And at the same time, there's an impression held by the public that a reduction of $1 in revenues means a reduction of $1 in research, which our committee would argue is not the case. It does not map to one-to-one. And in that regard, as best as we were able to determine that in recent years, I'm going to speak of the average drug company. There are specific examples that are quite different, but on average, drug companies spend more on marketing than they do on R&D. Spend more in the last 2 years on dividends and share repurchases and M&A than on R&D. They're among the most profitable industries, ranked number 1 and number 4 in net profit margin. So there are a lot of choices that a drug company should be able to make once revenues have dropped by $1. It doesn't necessarily mean that R&D drops by $1. It could mean that, but our argument is it doesn't have to.
It doesn't. In fact, at Merck, we spend 19% of each dollar on R&D. So we never said it was 100%. And I think at the end of the day, when you talk about profitability, what the market is asking is, what is the risk-adjusted return on invested capital? So if you're going to be in a business where you're going to spend billions of dollars and you're going to go after things like cancer and Alzheimer's, for which there is no cure, and you're taking the huge risk that you're going to fail, and we fail, over 90% of all the things that we start fail. So when you do win, it's a little bit of a jackpot industry. At the end of the day, if you're asking investors to put money at high risk, they've got to have a high return. So they look at what they call risk-adjusted return on capital. I mean, our business is a lot more risky, let's say, than the consumer food business is. And so at the end of the day, that's sort of what we look at. And I think it's, if you look at PEs of large pharmaceutical companies compared to the S&P, if you look at it, we're actually trading at a decrement to the S&P. And that's a lot of the scientific risk, but increasingly, it's the risk of whether or not there's going to be a market that's going to pay for your return.
I think to your point, the public also, I think, does not appreciate that when they buy a pill, that price of the pill is including the price of all the pills. Somebody has to pay for those.
Yeah, but I guess what I would add, and I think taking some of Ken's comments, you know, we're talking about certain classes and being very specific about the efficacy of those classes and the return versus extending them off-label, and I think Secretary Azar pointed to that as well. You know, I think we also, that's one subset, but we have significant costs inside of our system around not using generics, around combo therapies, the example Senator gave. There's other, we see them every single day where two generics, you know, that are very, very cost effective on the market are brought together under name bans, and one recently $3,000 for 60 pills. So you start to look at those scenarios and say, I think as we started this conversation, you've got to get into the specifics of what truly adds value to the system, and people have to have the transparency to make that. So we are very comfortable when we see that something has true outcomes and that it goes through the economic filter of best outcome across the system, and not just for pharma, but for everything across what overall total costs are going to be. I think that, you know, we have been very willing to pay for that, and you don't see rebates in those kind of drugs. You just don't. That's not, in Part D, less than 10% of those drugs are on rebates. So that, I think, is, quite frankly, a smokescreen as to the really true net cost issue that we're dealing with, not that it doesn't come up in conversation.
You're talking about the rebates?
Rebates, back to the, on Part D drugs, the rebates are less than 10% significant.
Yeah, but I'll challenge you on, say, insulin. Insulin, it may be $100 net cost, but a $400 cost. Now, industry's trying to make at least some industry, but I can tell you, my diabetics, there's a guy in Lafayette, Louisiana, that just wears me out because his daughter, the diabetic, is paying so much. So there are some Part D drugs in which rebates are an incredible percent of that list price. And if the patient's in the portion where she is paying 100%, she's getting hosed. I mean, she's getting hosed.
And I would say that's where you have to get to absolute net lowest cost. And, also place of administration, another issue that should be irrelevant, right, in terms of total cost. So I would agree with you. I mean, we completely support the issue of get to lowest net cost.
I want to ask one last question. I want to have time to open up to the entire audience. I'm sure they have lots of questions to ask. But I don't want to drift too far away from the conversation of innovation, because today we heard about the cancer innovation. And you're right, Ken. I mean, these are miraculous advances, which is amazing. And we did talk about the sustainability of this approach. And, we'd all agree that science innovation is moving at rapid pace. We've never seen as fast as this before, right? So the question is, can market catch up with, in fact, this pace of innovation? Can we, meaning setting price, et cetera? So this comes back to what's value-based pricing. And the earlier panel talked about, what's cost-effective. Let's look at each one and measure to one another. What are the mechanisms we can use to at least begin to have some way to assess what, in fact, should be the right cost for a major innovation that's saving lives, or maybe a Me Too, right? So how do we do that?
I think there's a couple ways to think about that, and I'll note that I spent last weekend at a cancer hospital in Florida where my dad's been recently diagnosed, and appreciate not just the fact that his physician took the time to walk through the options, but that there were options, and that I was able to go look at the cross trial and other evidence that she cited as to why she was choosing the regimen that she was choosing. So we want to be able to continue to bring forward innovation. I also want to have the ability that when I help my parents choose a plan every year, they have the ability to choose a plan that's going to work for them. And the Medicare Advantage announcement is done against the backdrop, if people don't like the MA plan that they chose, to have until the end of March to say that what you said you were going to do may not be what is actually happening or isn't working for me, so we're going to go somewhere else. I think value-based purchasing has a number of different meanings. I tend to prefer outcomes-based contracting as it relates to the conversation that we're having here. I think we don't believe that outcomes-based contracting on its own is a panacea to the concept of drug pricing. I think we do recognize that some of our rules may be in the way of bona fide contracting negotiations between plans and manufacturers that may want to agree on a bona fide therapeutic outcome and choose to contract based on that, but because of how our rules work, it may affect their other price reporting mechanisms. So we're looking at ways to get the government out of that. But like choice and competition, we believe that the private sector needs the tools that they have to be able to evaluate technology. And there's a fear that if the government tries to take on health technology assessment itself, it leads to that this is the government making a choice, and this is the government ultimately denying access to a drug that someone like my mom or dad could need.
Another way of thinking about it, though, is increasingly in cancer, we're actually looking at the genetic makeup of the person's tumor and trying to decide whether or not the medicine is an appropriate medicine for that patient. And that's another way of demonstrating value, another way of reducing costs to the system. In addition to developing medicines that have lesser toxicities and require less hospitalization. So I agree with the value-based contracting thing, but it's not the only way in which we can figure out value. If we can more precisely target medicines to the people for whom they will work in hepatitis C and cancer and those kinds of things, then we could actually also demonstrate greater value for the system.
Norm, any thoughts?
Well, just quickly, it's come up a little bit before, but to me, one of the important aspects of value judgments is what is the impact of a treatment today on reducing future costs? And there's a great deal of leverage in many cases there where something that might be rather expensive today will produce a net gain, discounted even, back to today's fund. So the trouble our committee had with value-based pricing, that was that although we all like the idea conceptually, that's basically the way you buy a car or a bicycle or an apple. The difficulty of determining value when people's lives are involved, even quality adjusted or what have you, it is just terribly difficult.
So, Senator, what if there were a totally independent, neutral, evidence-based organization that says, we're going to look at... Do you guys know of one? that when you have this amazing CAR T that comes through, that one does a deep dive assessment with economic modeling, and to at least recommend, like some organizations do so very independently, to say, here's where we'd say this should be, and have an ability to compare, if you will, what's there, what's in there, et cetera. I mean, is that something that could be considered?
I would favor a two-track process to kind of take what my co-panelists have already said. Australia has a way of evaluating medications, and if they decide that the medication doesn't really bring value, you can still get it, but you just have to pay the difference. So if there's a combo drug of over-the-counter Motrin with over-the-counter Pepcid, which would cost you $20 a month, but as a combination is going to cost you $2,000, well, if you want to pay $19,880, whatever it is, $900, then you can still get it if you wish. On the other hand, I used to treat Crohn's patients. Now, there's someone in this room who has Crohn's disease, and you're in this room, you're not in a hospital. And it used to be that the major cause of surgery in a Crohn's patient was previous surgery. And you would keep snipping away a portion of her bowel, portion of her bowel, portion of her bowel, because you could not control the inflammation. And give her high-dose steroids, and it was just a mess. And now they take an infusion once a month, and they're great. They're great. Talk about value, and they would figure that out just like that. Whoa, you don't need National Academy of Medicine to do that, because you have the insurance company saying, wait, one hospitalization pays for a heck of a lot of infusions. We're going the infusion route. So I think a two-tracked period, and I applaud the administration, I think we can also rely upon market phenomena. I will tell you, it is amazing the databases that once they're crossed together can give you information regarding patient outcomes. And so...
but you would agree it's somewhat fragmented at this time when you try to tackle this issue?
I totally agree it's fragmented.
Yeah. So I'm just simply saying that why shouldn't be a place, whatever the mechanism is, where we actually can look at it together.
I agree with that, but for example, I see Rebecca Gee in the audience. I did, maybe she's gone, but she's over there. So we've been working in Louisiana. What if we get X amount of dollars and we treat all of our hepatitis C patients who are medicated and in prison, and what would that do to real cost? Now, I'm a hepatologist. I know how to do a spreadsheet. I put it together. And using Medicaid data, which was difficult to come by. But Medicaid data is different than your data, which is, so the payer mixes something. It's going to be very hard for anybody, unless they are all seeing and all knowing, and that turns out to be God, in order to get everybody's data in a way that would be effective, not just for Medicaid, but also for Medicare, and also for a prison system. So I do think that at some point you got to introduce it into the real world, and introducing it into an MA plan may work.
But we got to get there.
Yes.
Okay, questions?
Art Kellerman, Uniformed Services University. Just two quick points. One, I haven't heard it from the panel, but just to remind y'all that a lot of the high-value discoveries that are funded by taxpayers at the NIH, the DOD, and through American academia. So taxpayers have a lot of skin in this game already. Not knocking the pharmaceutical, because you all helped bring it to market, but a lot of those game-changing discoveries are already paid for by the American people. Second, every system is designed to get the results it gets. And the way the market works in biomedical innovation today, you only make money by charging higher prices than the product you're replacing. If that was true in consumer electronics, this iPhone would be $250,000. So one thing, Rand wrote about this in 2013, if we rethink how we run the markets in biomedical research and reward innovation that lowers prices and gives rewards to the public, I think American ingenuity will knock this thing out of the park. But until we do, we're going to continue to try to replace drugs with a more expensive drug, technology with more expensive technologies. We need to change the underlying market signals. Like y'all, I believe in the market, but we have a market that rewards higher prices instead of a market that rewards better value. I'd be interested in what y'all think about both of those.
Anyone? Ken?
I'll make a couple of comments. So certainly it is definitely the case that everything that we do is based on basic research, which is essentially provided by NIH. The other side of that is, as I was saying about these immuno-oncology drugs, they come after decades of translational research inside pharmaceutical companies. So no question, without someone understanding, as we just saw, the Hancho just won the Nobel Prize for the discovery of PD-1. But it took forever for some companies then to say, how do you translate that into practice? There are thousands of those targets out there, and I mentioned before, we fail 90 to 95% of the time because those targets can't be reduced to practice. So the 5% are what we are actually bringing to market. So I don't disagree with you, but don't underestimate how much it costs to do the translational part of the research. And then on the last point that you made, I agree with the thrust of what you're saying, but I think we also have to look at the total cost of care. It's not just a question of whether drug A is more expensive than drug B. It's also, as we were just saying, whether or not that drug, when introduced into clinical practice, reduces the holistic cost of the disease. Again, I want to come back and say, we're having a discussion today about whether we can afford the newest cancer drugs. The question also is, can we afford cancer? Because cancer, the natural disease and its progression, has a much higher cost than the medicines.
The only thing I'd add to that is I agree that we need to fund innovation, but when we have new things added to therapeutic categories, costs should go down. So this is the only industry where we have not seen that. And we still see price increases for no improved outcome or effectiveness. So I think that's where I would disagree probably with my colleague here, is that I do believe that we, across many categories today, should see price decreases much more dramatically than we've seen with the introduction of competition. So.
And to that end, I think we are trying to send a signal with our payment rules to help pull through lower cost options like biosimilars. We are also in the questions that we're asking about rebates and about regulatory shenanigans and about patent thickets, trying to get exactly to the answer that Gail's describing about why some newer, lower cost technology may not be taken advantage of in the marketplace.
Question over there. Introduce yourself, please.
Gürkan Gardiner, applied statistician. My husband, who's also here today, and I attended a recent National Academies workshop on combination therapies. And at that conference, there was a statement from a member of the Food and Drug Administration, FDA, saying that a precedence is getting established for accepting the results of phase 1 trials in cases of application for combination therapies. For example, if one patent is about to run out and 2 pharmaceutical companies are trying to get together to apply for a combination drug, then the results from phase 1 would be evaluated without having for them to go through phase 1. I found that very informative. And also wanted to mention that as a comment to costs of going into combination therapy.
This is what I was implying. I mean, I agree with Ken. Our current FDA really does a really excellent job. But there has to be some real transformation, if not reformation, in the way we actually conduct these trials, the bars that we set, and accelerate some of this stuff, right? I mean, certainly in this day of big data and data analytics, maybe things will be different. But your point's well taken. I think in Japan you actually can get gene therapy into approval after phase 2 study, and then a provisional approval following to see what happens when you begin to apply it in a lot more patients. So there are creative ways of looking at this thing. Sandra? Okay. Yes, Eve.
Hi, I'm Eve Higginbotham from the University of Pennsylvania, and I'd like to thank the panel for taking on this extraordinarily important topic, given the pressures this has on our patients, as well as those hospitals and facilities that take care of vulnerable populations. And so that's my question. And so it's specifically to Senator Cassidy and Deputy Assistant Secretary O'Brien. Given the 340B drug policy and the current conversation around reform and cuts and what that can do to these hospital systems that take care of vulnerable populations. And Senator Cassidy, I'm originally from New Orleans and did my residency at Charity Hospital. So a safety net hospital is critically important to me. Can you give us some insight in terms of what this administration is considering as it relates to reform around the 340B drug pricing policy, as well as possibly the opportunity to apply some different rules around it? If I know, Senator Cassidy, you mentioned there was some concern about fraud. Thank you.
Yeah, I'll let John talk about the administration, but I'll just say that everybody recognizes that 340B has a very important role. And as originally intended, was to bring lower cost drugs to those which need it. But in some hands, it's become a racket. And I mean that. And the benefit is not getting to the patient. So much so that there are in some entities in which the patient who is uninsured will go and pay the full cash list price and not get the benefit of the 340B pricing, and the delta goes back to the hospital. And keep in mind that this is structured on inpatient population, but has nothing to do with outpatient. So unlike Charity Hospital, where you and I trained, the patient can come in through the ER, get treated, get sent back home, but now is when they need the medicine, and they don't have follow-up through that facility. And I spoke earlier of evidence that there is actually less oncologic treatment for Medicaid and uninsured in 340B facilities relative to those which are not 340B. Now, I will tell you, I worked in a hospital for the uninsured, and 340B made medicines available to those who otherwise would not have. So on the one hand, I see it as an incredibly important lifeline, and on the other hand, as something which is being exploited for profit, but not for the original purpose. And that's kind of maybe my theme throughout this whole time.
Well, I don't know if I'm allowed to say the word racket without going through clearance, but I will certainly echo the senator's statement and recognize that the program has certainly grown by leaps and bounds in recent years, and that we asked some questions about the growth of that program and whether or not it's continuing to function the way it was intended to function when the Veterans Health Care Act was passed, ultimately without a conference report, which makes it difficult to understand everything about intent at that time. But what we've done is we've certainly read all of the research and publications about the growth of this program, the concerns about the relationship to the program and the growth in Medicare spending, and what MedPAC and others have stated about the acquisition cost of 340B drugs and what Medicare is reimbursing for those 340B drugs for Medicare Part B beneficiaries. Because a Part B beneficiary pays a coinsurance based on the cost of the drug or the service, we proposed and ultimately finalized a rule that would reimburse 340B drugs at ASP less 22.5%, because MedPAC described a much lower acquisition cost. That policy, which we finalized, is expected to save seniors $320 million this year on out-of-pocket spending. That's not government spending, that's out of seniors' pockets. What we also proposed in the president's budget was to be able to take the savings that are caused by the government spending less on those drugs and redistributing those savings to the hospitals that are providing the greatest levels of charity care. We're continuing to seek feedback on this topic so that we do get the right balance between a very important program in serving low-income uninsured at the institutions where that's happening, and what is being described as significant growth beyond what Congress intended.
Yes.
Nelly Ulrich, I'm director of the Comprehensive Cancer Center at Huntsman Cancer Institute in Utah. From what I understand, the administration now tries to put a lot of emphasis on consumer choice. And that means, similar to when you buy a car, you can make decisions about pricing and what you want or what you don't want. Now, my understanding is in healthcare, we have a little bit of a different situation. First of all, with respect to the information that needs to be made to the patient understandable and clear. So there's no Kelly Blue Book out there, even though people are trying to do that. And second, that price sensitivity is rather limited among patients because it's about their own lives. It's about the lives of their family members, etc. So how do you see this? How likely is it that consumer choice will really have an impact? Because I thought that had been tried before and was not successful.
Sandra?
So first, obviously the drug market is not monolithic. There's generic, there's name brand, there's small molecule, there's specialty. But within that, you have a great deal of variation. Consumer Reports sent out secret shoppers as if they were uninsured paying cash for medicine. Uninsured paying cash. And 7 different drugs. One drug, as an example, the price a consumer could pay ranged from $44 to $740. A generic drug. Clearly the acquisition price is somewhere south of $44. And some were getting charged $740. Now this, in my mind, is unconscionable. And this is where I think there needs to be, you should have consumer choice. And you should push it out there. Not just, okay, I knock on the door, I can't believe it's $740, I guess that's what they charge. No. It's like when I was a kid and the newspaper used to have a listing of everything that things cost. It should be like that, in that generic space, where the patient should know when she goes to the pharmacy or when she goes online, she is able to comparatively shop. And other things, you're right. If it's a branded drug for which there is no alternative, you're going to need a physician to guide you through. I get that. But there's a lot of savings to be achieved outside of that situation. And by the way, going back to, and again, Gail and I will disagree, you can look at the list price, not net of rebate, but with rebate, and patients who are in a $6,000 deductible are getting hosed. They're getting hosed. And they're paying full price, not the, post-rebate price. And then that, of course, gets clawed back by some of the PBMs. You can argue it goes back to subsidized insurance premiums. What we're saying is the sicker patient paying for the more expensive drug is subsidizing those who are better off.
Right.
Senator,
there are actually 2 issues that I hear from patients. Number one is the one that you talked about, which is they don't get the benefit of the rebates. They don't pass through to the counter. The other one is that often insurance policies require them to pay as a percentage, a higher percentage of the drug cost, which is of the list price, versus a percentage of in-network hospitals or in-network physicians. So often they'll pay 15% of a list price rather than 3% of a net price.
Yeah, well, let me correct that, because that actually is in our policies. You can look at all of our policies in Anthem, go through, our employers. We actually take it off of the negotiated price. So that's been a policy from day one.
For you guys.
Well, I can speak to what we do, but I'm sure there may be other choices, but we've been very clear. Again, because for us, it is about total cost.
Yep. And I'd thank Senator Cassidy for his leadership on price transparency. Again, the action that we took today on proposing to require list prices to be included in ads is because most patients pay either on list price or the list price itself. We're also exploring other ways to get good information and better information out to consumers. Secretary strongly believes you ought to know how much a drug's going to cost and how much it costs you long before you get to the pharmacy counter or get a bill in the mail. I think the rebate system is another opaque system that we need to look into. And something that Gail alluded to earlier, site neutrality, is another important part of our transparency effort.
Okay, we'll take 2 more questions. Rebecca.
Cassidy, Secretary of Health for Louisiana, and in charge of the Medicaid program. So first I wanted to thank the National Academy for your report, which I was able to participate on. The Cassidy, many members of the Academy who helped us in Louisiana, thank you, with our solution on hepatitis C, which we're including Ken and AbbVie and Gilead, who have been very, very resourceful and open to new solutions. So there is hope for states, but two problems, and really, John, this is for you and Senator Cassidy. So one is that the denial of Massachusetts to not have drugs on its formulary that are of low value compared to other drugs had a chilling effect, I think, on other states. So what tools are we going to have if a drug is more expensive than another, doesn't work as well? What new tools are you thinking about giving states, number one? Number two, is there lots of market failures? I'm a practicing OB, and 2 weeks ago I was seeing a patient in clinic who had syphilis, and what I realized was what was a $5 drug, penicillin, is now between $400 to $3,200 because now there's no generic. I could not get it for this woman's partner. CVS and Walgreens won't stock it because it's too expensive. The same thing, by the way, for 17-hydroxyprogesterone, the only hormonal treatment for prematurity, and has been around since the 70s. So what do we do about this type of predatory pricing? And then finally, if you could, areas that are just neglected for research because Ken's company is not going to make money on it. So for example, contraceptives, maybe the leading issue of our time is population, right? No meaningful improvement in contraceptives since the 1970s. Very little, IUDs have been around since then. Really not a lot of exciting.
You should talk about Implanon and Nexplanon, the implantables.
Implantables, yeah, but those have been around a long time.
Right. Well, those are new.
Long time. So not a lot of innovation in areas, or sickle cell disease, diseases that affect low-income people who are vulnerable, who are never going to have the money to pay for them. So what do we do about those market failures in areas where there are not incentives for profit, and for-profit companies are not going to be incentivized really to do the R&D?
So you got a lot. You got a lot of question in a short amount of time. I will do my best to do the same. Our budget proposed allowing 5 states to do the kind of testing that Massachusetts sought to do. I think the specific issue with Massachusetts was related to whether or not they wanted to hold on to the Medicaid drug rebate program mandatory rebate in addition to any additional discounts that they were able to negotiate. So I think there's some open questions that we had proposed to test, and would certainly love to talk more about that. On one market failure that we're trying to correct, the Secretary has directed FDA that for single source, brand or generic, drugs for which there is no patent protection, to develop a mechanism by which we could import those drugs from other countries to be able to get off or get after the instances of that happening where people aren't able to get a drug, or because the price has essentially made it unaffordable. And we've met with you and your colleagues and the governors, and continue to hope to do so. We've heard about Netflix and Netflix Plus and all of the other different approaches to contracting that, again, our rules may be in the way of long-term financing plus outcomes, et cetera. So to the extent that we can address our rules to unleash state innovation to allow you to do what we think you know how to do best, that's something that I'd say stay tuned for.
And on the profit incentives for research, that is a real concern. Let me start by saying that at Merck, our philosophy is that we follow the science. We don't just say we want to go after sickle cell versus another area. But we do go into areas where, frankly, there's not much of a commercial opportunity. We were very proud of our Ebola vaccine and the impact that that's now having in sub-Saharan Africa. That is not a commercial opportunity. That is simply that we are doing research in an analogous area in our vaccine research. The researchers came forward and said, we think we can do something about Ebola, and we put the money up to do it because that's how you get the next generation of scientists to come to your company. Another area is antibiotic research. Right now, the work that we're doing on antibiotics, we do fully knowing that if we're successful as a matter of antibiotic stewardship, we should take those new antibiotics and put them in the medicine cabinet so that they will be a last line of defense where people have all the antibiotic resistance, which is growing at an amazing rate around the world.
Senator?
First, what John is talking about, of course, is, let me start over. On our website, cassidy.senate.gov, we have something, ideas to help make healthcare affordable again. And we have stuff in there such as importation of drugs, not reimportation, but it's an acknowledgement that many of the medications that go to Europe and to the US are made in India or China. And there are secure supply chains that would bring this drug to Germany as well as to the US. And so why can't a US company then go and buy from London the tetracycline that seems to be way too expensive here, or the doxycycline, as opposed to just have only to be a price taker? Again, the EU is equivalent to the FDA, and the FDA have an MOU that if one inspects the plant in India, the other will accept that inspection. And so it just seems logical that we should have a global market for some of these drugs. So I like that, John. I think it's a great idea to go after these, again, generic small molecules as an example. But as regards to sickle cell, I think that's also something where there needs to be this symbiosis between what research is and value-based purchasing. Man, aside from just the tragedy of a sickle child, it is the expense of a sickle child. And if you can do gene therapy and find that one gene, I was in a conversation walking to LSU's big victory over Georgia, boom.
Go Gators.
And the doc walking with me was telling me, so this is a little bit of hearsay, but you know, there's really a very small gene that could be replaced in the genome of a sickle patient and make a huge difference. Talk about something where compassion meets value-based purchasing. And so the degree to which we can do that, I think, should be opportunities for that directed research.
And that science is being carried out.
Yes.
Yeah, that's for sure. Last question, George. Short.
My name is George Hill from Vanderbilt University. And I want to come back to what Ken Fraser said as we wrap up, and that is the patient. And throughout today, we've talked a lot about, and we've heard a lot about, the disparities that occur with one population versus another, racial disparities. And I wonder for the congressman, for the senator, and for Ken Fraser and representative from HHS, and I'm thinking in terms of my barber, or somebody that is on Market Street in Philadelphia, or in Canal Street in New Orleans, or over in Camden. What is it you would say to individuals who say that the issue of health disparities and issues of difference in terms of health care or incidence of disease is not something that individuals like yourselves think about? How would you respond to that?
Well, first of all, I think it is all of our collective responsibility. We put a lot on the government, but my own philosophy is government is just a word that we use in our society to decide what are the things that we want to do together. I don't think it's just these officials, it's what we care about. As a company, we think those are major issues. Just one example is that we have spent in the last few years, and the next few years, we've committed $500 million to doing something about maternal mortality. In New York City, an African-American woman is 12 times more likely to die in childbirth than a white counterpart. It doesn't matter what her education level is. It doesn't matter her economic situation. That is a crime. If you look at heterosexual transmission of HIV in the black community, I always say, I don't want to be inappropriate, if that was happening in another community, it would be on the front pages of the newspapers, the same way now there's an opioid issue on the front pages of newspapers. So we think that we have a responsibility as a pharmaceutical company to work with the government and others to deal with those healthcare disparities, because we're all Americans and our lives are all equally valued.
Thank you. Thank you, George. So, some last words. I'm very encouraged from today's discussion, starting with Secretary Azar, and of course, every one of you. Certainly, Ken, you captured it well. I think we all want to do the right thing. And there's certainly a lot of activities, actions being taken. But as a poor country doc, I'm also somewhat discouraged about how complex this issue is. Yeah. And we're fixing one piece at a time, right? And you know, something tells me that it needs a total transformational system fix. But can we get there? Maybe if I can ask each one of you to just say one word, what do you want to do? How can we get there? Start with you, Senator.
I don't think I think it's, let me start over. In all due respect, I'm not so arrogant to think that I could come up with that one thing that would fix it all. I am much more comfortable with singles and doubles and let's see what happens. And then you adjust it after that. And I think that is the better way to get to a system. But your guiding principle should be market forces with transparency, not opaqueness, and making sure that the patient and the taxpayer are cared for as opposed to being those who are exploited.
You would agree that we're going to have to move fairly quickly because what you see is these issues really ahead of what we're able to kind of respond to, right?
Oh, yes.
So, yeah.
And this president will break an egg. And so this president will take 18 eggs and slam them upside down. And so I do think that we have a president who would be willing to move quickly.
Ken?
Very quickly, I'll have to repeat what I said. I think simple answers are cop-outs. These are complex issues. We're going to have to engage across multiple people to get the answer. But I think if there's one theme I would say is what is good for the patient.
Thank you. Gail?
So I will concur. I think it's way too complex. I do think we can get to greater simplicity. I also agree that holistic pronouncements don't do it. I think transparency is critical. And I think we have to really establish value because someone ultimately is making choices because of the cost of this system. And I think that, again, dealing with only certain issues doesn't solve it. So I think we have to get to transparency and total cost and outcome. And really, I think the conversation about it's not so much value, but it's pay for outcome with very specific patient populations.
John?
I'd echo what the other panelists and the Secretary said. I'd reiterate the Secretary's testimony that there is no single silver bullet that is going to solve this problem. There is no one stakeholder that is to blame. We're going after or working with everybody, and that we have a president who is passionate about this topic, has demanded action, has done more than any president, and has encouraged us to make sure that we have every option on the table to ultimately get the outcome we need.
Norman?
I would just observe that as a nation, we spend 18% of our GDP on health care. 17% of that 18% is on pharmaceuticals. Pharmaceuticals are the highest growth rate within healthcare except for administration. The next highest nation in the world spends 11%. And if you look at what we could buy as a nation with 7% of our GDP, there's enormous opportunity cost here. And given that and the importance to patients, of which I've been one, I just thank the Academy and you, Victor, for putting this on the table and devoting so much effort to it, your personal effort.
Thank you very much, and thank all of you for being a great audience.
Thank you, Victor.
I'm glad you made it.
Yes, I enjoyed it. Thank you.